Hey guys, this is Dr. Kim. Another great case to share with you. So go ahead and take a look at this bite wing radiograph. Resolution on your screen might not be perhaps as good because I'm unable to open these individual radiographs. So you're looking at a full set of bite wing radiographs. This is a 16-year-old male patient, and if you look here, you see that number 31 did not erupt, right? It should have been erupted at around the age of 12, and the patient is 16 and did not erupt. Just from this biting radiograph, you just don't have enough radiographic information to make any good evaluation of the tooth, and therefore we have panoramic radiograph, right? And it's clear that not only number 31 is impacted, number 17 is horizontally impacted as well. And we see this radiolucency that appears to be like just below the crown of that tooth. And based on that, we can make some differential diagnosis. But the reason I'm showing you this case today is we have not only the Comim CT scan of the patient, but I also have definitive diagnosis. We have result from our histopathologist or our pathologist, and we know what this is. So let's take a look at the lesion three-dimensionally. Keep in mind it appears flipped, and then let's take a look at the coronal view first. So I'm going to move back to the posterior ends of the scan and move anteriorly. That's number 32, and here we have 31. Two roots, all right, and then the mesial root appears to be bifurcating into two different canals, and there is a mandibular canal that's running, buccal to those roots, and we can see that from this axial view as well, right? So we have number 31, and the canal is positioned buccal. And let's continue to pay attention to our coronal section as I move anteriorly. And we saw that there was a lesion, at least from panoramic radiograph, that's below the crown. But the new information we have here, is that the lesion appears to extend buccally as well, and has caused rather significant thinning of the buccal cortical plate. Furthermore, I want you to see that this lesion has caused some resorption of the root. Now let's look at this in the axial plane. Again, there's that resorption that I talked about, and then the buccal expansion of the lesion into the buccal cortex. And thankfully, I don't see a very significant resorption at number 30. I think what was unique for me was that this is expanding primarily in the buccal and inferior direction, and that there is really no expansion whatsoever at the level of the occlusal plane. Now let's recap that information from the sagittal view. It's very similar to what we saw right from panoramic radiograph, that well-corticated pericoronal radiolucency, and there is the site of resorption. Okay, so again, the information that we have, new information, is the buccal expansion of the lesion and then the resorption, and we can certainly better visualize the relationship between the roots and then the mandibular canal that runs just adjacent to it. So here's my tracing of the mandibular canal. Here's the impacted tooth. The buccal cortex is very thin in this area. And let me kind of gently move away the bone. I wish I can still leave the roots behind, but because of the radiodensity, I have to remove, looks like both of them at once. at the same time. Anyway, so drum roll please. I might have shared this case before, I can't exactly remember, but I certainly didn't share the final diagnosis. So this is dentigerous cyst. This is a dentigerous cyst, and it's good to know for all of us that dentigerous cyst can be an asymmetric expansion of the pericoronal space or pericoronal follicle. Generally speaking, most dentigerous that I've seen, the expansion tends to occur right in the occlusal space, but in this case, probably due to its impaction and then the fact that number 32 is preventing this tooth to move posteriorly as the lesion is growing, it probably found that the least path resistance of its pathway is into the trabecular bone, hence it's expanded into the trabecular bone instead. But I would have it would have been a little bit easier for me to diagnose had this been displaced posteriorly, but there was no evidence of being displaced posteriorly. So at the time, I think when I first looked at this, in my mind, I certainly considered keratocystic, odontogenic keratocyst, but this came back as dentigerous cyst. So very, very interesting case. And both of these teeth now have been removed. And what I heard from the student is that at the time of removal, he was able to actually visualize the canal, because you can see how close the canal is to the roots. So when the roots are removed, he was able to see the mandibular canal, and we're a little concerned that this procedure may cause nerve damage, but thankfully patient has no signs of nerve damage after the surgery. So it was a thankfully successful outcome, and it could not have gone any better. So that's all for me for this video. I hope you found this helpful, and until next time, take care.